Good afternoon, everyone. I'm Janice Whitaker, CGNE Administrator and Education Program Manager. This program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carol Neese College of Nursing in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care Pennsylvania. Today's seminar, Improving End-of-Life Care for All, Strategies to Educate, Innovate, and Reach the Underserved, will be presented by Dr. Crimi, former CGNE postdoctoral scholar who now serves as director at the Wright Center. Before we introduce the speaker further, there are some announcements and disclosures to make. Penn State Ross and Carol Neese College of Nursing is approved as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Participants with a valid RN license that attend the entire activity and complete the post-event evaluation within 1 week can earn 1 contact hour. Partial contact hours are not awarded. Certificates will be emailed to RNs meeting all the requirements within 1 month following the seminar. As a reminder, the seminar is being recorded. And if you have questions or comments for the speaker during her presentation, and certainly after, during our discussion portion, you can enter those into the chat. We'll be monitoring the chat, so please use that. If you'd like to raise your hand and speak aloud, please use that raise hand speaker feature at the bottom of your screen. And as a reminder, the post-event evaluation link will pop up in your browser when this webinar concludes. It will also be emailed to you within 24 hours. This is required for RNs seeking contact hours, but we do ask that all attendees complete the evaluation for our data collection. If you have any questions or comments, you're free to reach out to us at cgne@psu.edu. Next, Jenny Rank has an additional announcement for our participants today.
Thanks, Janice. I just want to give everybody a quick update that we've been having some issues with the Zoom registration. And for whatever reason, all of you might be getting some emails saying that the Zoom has been rescheduled, our seminars are getting rescheduled or edited. So I just want to let you know that our IT team is working on it. But our next 2 seminars are December 3rd and December 10th. And those are kind of the next 2. So if you see other dates or get those messages, just disregard them for now.
Thank you, Jenny. Now I'd like to introduce Solomon Tagbor. He's a CGNE affiliate graduate student in his 2nd year of his PhD program. Solomon is a very active participant in opportunities provided by our center, including our Gero RIG, our research interest group. He also recently attended a hospice and palliative care conference at Mount Nittany Medical Center and has attended the NHCGNE virtual conference recently as well. Thank you, Solomon, for introducing our speaker today.
Thank you, Janice. Dr. Crimi is a PhD holder and a registered nurse. Is the Director of Quality, Safety, and Emergency Preparedness at the Wright Center and a registered nurse at Hospice of the Sacred Heart. She has clinical and academic expertise in hospice and end-of-life care. Her work centers on improving knowledge and attitudes around end-of-life care, improving access, quality, and education in hospice care for vulnerable populations. Dr. Crimi's research explores the intersection of education, practice, and policy that advance equitable person-centered care, the end of life. Join me to invite Dr. Crimi to take us through today's presentation. Dr. Kale, you can take off. Thank you.
Thank you, Solomon. That was such a warm introduction. And thank you, Janice and Jenny, for everything that you've done and have told our lovely participants about. I'm going to share my screen here. And hi, everyone. I know we have a good attendance, but I can't see everyone, but I'm really happy that you're here. And I'm excited to talk to you today about improving end-of-life care for all and strategies to educate, innovate, and research the underserved populations. My name is Calais, and let's get started. So the objectives for today is to identify gaps in care and rural disparities in patients at the end of life. We're going to address some opportunities to strengthen nursing education and practice. This will be at the undergraduate level, the graduate level, and also too for our nurses that are at the bedside in the workforce. And then also identify at least 2 best practices or innovative roles that can enhance end-of-life care for vulnerable populations. So I'd like to begin our conversation today with a reflective activity. And I'm going to walk you through it, and our friends Solomon, Jenny, and Janice are going to help monitor the chat for me. But I want you to stop and think and reflect. I want, no matter what phase of your career that you are in, if you're still at the bedside, if you've removed yourself from the bedside, if you're in academia, if you're in the workforce, I want you to imagine that you're a nurse leader in a small rural hospital. Think of maybe one that's close to you or where you've lived prior. You're caring for a patient that has end-stage heart failure, and he's declining, and it's projected that he's only going to live for another month. The nearest inpatient hospice facility is about 50 miles away. They don't have an available bed for the foreseeable few days. And the nearest hospice agency is about 60 miles away from the patient's home. The family and the patient live in a really remote area of Pennsylvania, very rural. It's winter and a large snowstorm is approaching later in the week, which puts a little bit of pressure when we're thinking about transitions of care. Your staff on the unit has very limited palliative care and hospice training. The patient tells you directly, I want to die at home. So I want you to sit and think and mull with that information. And I want to hear what you think the biggest challenge is that you see here. What is the biggest challenge in this scenario?
Just a reminder to put that biggest challenge that you think into the chat.
Yes, thank you, Jenny. Yeah, tell us in the chat. Share with others.
Yeah, so access is one thing that's been written. Access to the center itself, the palliative care center. Casey's saying lack of resources.
Lack of resources. Yeah, definitely lack of access to those hospice facilities in the hospice agency.
Yeah, and Ariel is saying, golly, so many here. First, I think, okay, we know the patient's goals, and he wants to stay at home. How can we get him home, and how much time do we really have? Of course, issues with weather, access to care, training, resources for staff in general is a concern. And Solomon is echoing that, saying limited skill set. Donna Fick is saying knowledge and understanding, possibly attitude. Mary, access to services, both personnel and equipment. Crystal, resource availability issues. Sherry Ard, also does everyone, including the family, truly understand end-of-life issues? Resources, and once home, can hospice see him? So lots to think about, Calais.
That's wonderful. And I appreciate the diversity in answers. And I hope if this teaches us anything, is that none of these challenges are more important than the other. They're all very valid concerns and valid barriers towards patients in rural areas receiving hospice care. I really appreciate the diversity in perspectives. We had some people talk about accessibility, some people talk about the nurses and the nurses' scope and capability in providing good quality, high quality end of life care. I've heard some things about the weather and the dynamics of physically accessing and then also utilizing hospice as well. And all of those answers are correct. And I really appreciate everyone's thoughtfulness in crafting those responses.
Calais, one additional comment from Donna is that she says prior experience with dying.
Yeah,
which I
prior
think is
experience.
incredibly
I wonder
important too.
if would that be for the patient or would that be for the staff?
Probably everyone, right?
Probably everyone. Yeah. Yeah. And that I think plays into, I think Donna said earlier about attitudes and how previous experiences really tie into one's attitudes and around death and dying, whether that's the patient, the families, the staff caring for the patient, all of that's really important. And we're going to talk a little bit more about that soon. So this situation, while it seems very grandiose and large, situations like this happen every day in rural communities across Pennsylvania and across the United States. And I think if this highlights anything, it's going to highlight why innovation, education, and equity really must intersect to improve the quality of care our patients are receiving every day. So if you didn't know, November is National Hospice and Palliative Care Month, which I always get really excited about because this is the month that we really love to promote educational resources for community members, for working nursing workforces, for the broader population to bring awareness to what hospice care is, what palliative care is, how they intersect and can really improve the quality of life patients and families receive with terminal diagnoses. For those of you who might not be familiar with the difference of hospice and palliative care, hospice care specifically is for patients experiencing a terminal illness with a life expectancy of less than 6 months or less to live as diagnosed by their clinician. It's based on the belief that everyone has the right to die pain-free and with dignity, and the focus is on compassion, caring, quality of life, and not curing their terminal illness. Hospice helps patients and their families and caregivers live their life to their fullest. And oftentimes, this includes patients with terminal illnesses such as Alzheimer's, cancers, strokes, and we'll talk a little bit more about that too. Palliative care is a specialized interdisciplinary focused care that treats the symptoms of a patient or a person who is suffering related to an illness or an acute event at any stage of a diagnosis. And I mentioned, so this could be a chronic illness. This could also be an acute event after someone might have gone through a serious traumatic injury, motor vehicle accident I've seen prior, really any type of acute injury that would require symptom management to help alleviate their symptom burden and reduce and improve their quality of life. The goal is to improve their quality of life and provide symptom management, and ultimately that leads to higher patient satisfaction in their care. Especially when you think about our patients that have chronic illnesses or multiple chronic illnesses and how they're managed, they often have a high burden rate related to those illnesses and the symptoms that they're experiencing. Palliative care is a great way to help them improve and satisfy their care. And although palliative care is a key component to hospice care, palliative care is not restricted to patients with terminal conditions. And so this is another key aspect of palliative care, which differentiates itself from hospice care. So I always like to bring this up in November because while you might be familiar with this, or maybe you're not familiar with this, I hope that you walk away today and are able to share these differences with a loved one, with a patient, with a friend who might not know these differences between hospice and palliative care to improve the utilization of these resources in your community. So we talk a little bit about vulnerable populations today, and I really want to hone into a few different areas of vulnerable populations, but most of this presentation is going to surround rural end-of-life care, which is a subcategory of vulnerable populations in regards to end-of-life care. So some settings that end-of-life care is provided in rural areas can be community-based, and this is the most common or most prevalent area, and this is often organized by local health professionals and subsets of volunteers that serve one or more rural areas. Many of these community-based organizations are really dependent on volunteers that come in and help with care of the patients when it comes to keeping them company or helping the families, providing them with meals, socialization to the patients and the families. There's also hospital-based end-of-life care options. Some rural access hospitals or hospitals in rural areas will set aside a few beds of what they will call a hospice bed, where they're able to provide hospice services and symptom management and care of dying patients in those settings. We also have home health agencies or home hospice agencies that will provide end-of-life care, and then county health department sponsored care as well. And this care can be delivered anywhere the patient is existing. So this might be in the patient's home, in their private residence, and a family member's residence who took that patient in and is caring for them and helping in the caregiving process of that patient. It might be in an assisted living facility, in a nursing home, in an inpatient hospice unit, if you're lucky to have one available or close to the patient's residence. It might be in a hospital, like I mentioned, or in a hospice house, which is a little bit more uncommon in some areas across the United States. So to give you an idea of what the current state of hospice care looks like, most of this information has been released through CMS in 2025. So this is overlooking data over the last several years and really capturing the 2020 to 2024 range of data when it comes to Medicare and hospice patients and utilization of hospice services. So recently it was found that annually over 1.7 million Americans are receiving hospice care, and they're most commonly enrolled with the following diagnoses, and I listed these in order of most commonly enrolled. Cancers are our biggest enrolling diagnosis of all types. Alzheimer's, dementias, and Parkinson's. We have cardiac-related diseases, most commonly is CHF. Patients who have experienced a stroke or CVA, and patients with respiratory illnesses such as COPD. And over 50% of Medicare descendants die in hospice care. So if you look at the chart to the right, where it says deaths inside and outside of hospice for the financial year of 2020 to 2024, if you look at 2020 to 2024, you're going to see a small dip in 21 and 22 of deaths in hospice, but we are slowly starting to rise again. And on average, over 50% of our Medicare patients who are dying in hospice care. Now, this is a large improvement because if you go back to the data from 2010, 2012, 2013, these percentages were drastically lower. So we are seeing steady improvement, but we also have a large amount of patients that we're still not accessing, and utilizing hospice care. And so it's really important to ensure that all patients have a high quality death and dignified death, that we're providing them with the proper resources and care care components to be able to integrate that. And despite steady growth, the geographic and demographic disparities are still persisting. And persistent disparities really are happening most commonly in rural settings, correctional settings, and minority populations. So I want to break that down further to the utilization of hospice services in rural areas. And so looking at this chart to the left here, this is from CMS, and this is the percentage of Medicare descendants who use hospice services. So it's broken down into several beneficiary locations: urban, micropolitan, rural, adjacent to an urban setting, rural, non-adjacent to urban settings, and then we have frontier. And that's defined as a population density equal to or less than 1 or 6 people per 1 square mile that overlaps the categories of residents, just to give a little bit of context there. And what we see when we're looking at these numbers from 2010 to 2023 is that we overall, since 2010, we have seen an increase of Medicare descendants who have utilized hospice services. It's really amazing to see the growth in some of these areas. However, while we have an overall rise in utilization of hospice services, there's still a really large equity gap. And while hospices have grown everywhere, rural and frontier areas are continuing to lag behind in utilization of hospice services. Additionally, we're going to note some access improvements. The largest growth occurred in rural areas adjacent to urban centers, and this can suggest that because of that proximity to the urban area, those patients might have better accessibility to hospice providers that help enhance and access their care. Additionally, we see persistent barriers in the frontier region, and this shows the least amount of improvement, and this could likely be due to workforce shortages, limited hospice infrastructure, and long distance travel to delivering care to those patients and their families, which we're going to talk a little bit more soon. So overall, we are seeing improvements, but there's so much more that we can do and needs to be done to provide high quality care to these patients. So I want to talk about some barriers that currently exist through the literature in providing end-of-life care to patients in rural settings. One of them is demographics, and rural populations tend to be patients who are older with higher rates of chronic disease and disability and having multiple chronic illnesses leading to their disabilities. And so this makes their care a little bit more complex, a little bit more challenging, and this is one of the barriers to care. Additionally, we have workforce shortages, and this is nationally, urban and non-urban settings, but specifically when it comes to rural and frontier areas, we have a really challenging time recruiting, retaining clinicians, nurses, specialists, volunteers in rural areas. And this leads to persistent gaps in care. And we also have high rates of burnout because we are dealing with a smaller population of people who are able to provide that care and have more demands on their job when it comes to the distances they're traveling, the patient loads they might have, and that ultimately leads to staff burnout. Additionally, we have infrastructure and access barriers, and that could be due to geographic distance, weaker broadband connectivity compound issues for telehealth visits when that is feasible and is utilized by the patients and families. There is still some financial strain issues such as reimbursements and operating cost problems, and we have stringent federal regulations and policies, some of which are changing. But one of them that a lot of providers are currently facing is the requirement for face-to-face visits for recertifications for hospice patients. Now, I want to look at more specifically to nursing and the nursing profession. When reviewing the literature, these are the 3 highlighted on the left-hand side are some of the largest barriers we see impacting patient care in rural settings. And the first one is coping with the fear and anger among patients and families who are having a difficult time accepting their loved ones or the patient's injury or illness. And this comes back to being able to have conversations to educate the patient and family. And when providers and nurses aren't able to do that, they have a difficult time accepting that strain in the relationship and developing a rapport with that patient. Additionally, you have to tie into the emotional stress of caring for dying patients whom they have close relationships with. Oftentimes, if you have a patient in a rural setting that's receiving home hospice services, you might have a nurse that has been following with that patient for several weeks, several months, getting to know them in a very intimate way, providing dignified care. And that could really lead to a lot of emotional stress as those relationships become terminated and the patient dies and the nurse is transitioning to caring for other patients. Additionally, we have a lack of training programs nationally for nurses geared specifically to nurses who wish to specialize in hospice and palliative care services. We have certificates that are being removed from universities. We have lack of access and training and knowledge in these areas and experts helping to develop this gap in knowledge. Additionally, we have low retention rates among rural staff. There's the physical stress related to lifting heavy weights because oftentimes you're the only nurse in an area helping to move these patients, and you're by yourself. It puts you at risk for a work-related injury. The salary for rural areas for nurses is typically much lower than those earned by nurses in other specialties in rural areas or nurses caring for hospice patients in an urban setting. And the skill set for caring for patients in rural settings at the end of life is very complex. These patients have many chronic conditions, and these skill sets is niche, and you have to have a nurse who has good training and experience in these conditions. You're often working alone without support. Often you have less access to medications and equipment at a timely manner. And additionally, there's safety concerns. The reflective activity that we brought up earlier talked about a snowstorm coming later in the end of the week. And that is a very valid concern for some of our nurses providing end-of-life care to patients in rural settings and accessing them during those natural storms. So what can we do? One area we could focus on is education, and specifically nursing education and workforce preparation. So one of the first ways to do this is integrating hospice and palliative care content throughout nursing curriculum. And the importance here is there's currently not much consistency recognized nationally for how students and educators are preparing students to learn about end-of-life care in their programs. Some programs might offer students a clinical experience. Some students might only engage in one 30-minute PowerPoint on end-of-life care topics. But what really is recommended through the literature is scaffolding palliative and nursing and hospice nursing concepts throughout curriculum from years 2 to 4 or 1 through 4 as they're learning and building their nursing knowledge and critical thinking skills. And this recommendation comes through AACN Essentials, which tells us that our nursing students need to be prepared to provide end-of-life care upon graduating from a bachelor's program. Additionally, we want to encourage the use of interdisciplinary education. I mentioned earlier that hospice and palliative care are very specific in ensuring that the care that is provided in these sectors is interdisciplinary in nature. We're utilizing medicine, physical therapy, occupational therapy, social work, pharmacy, chaplaincy. And so we have to encourage that interdisciplinary development early on in nursing students' career to prepare them as they transition into the bedside. Additionally, we have content through LNEC, which is the End of Life Nursing Education Consortium, and they've developed online training modules which they continue to develop and improve and update every so many years. And this provides specific end-of-life care education for undergraduate nursing students. They have certificates for graduate level students, and even learners who are nurses who have already graduated from a program and are just interested and learning more about end-of-life care. And so I really encourage the utilization of these resources. It's supported through the literature, and is a great way to develop these skill sets for those who need training or extra education in these skills. Additionally, one way we could improve the education at the undergraduate level is focusing on rural clinical placements related to end-of-life care or hospice settings, developing community partnerships. These areas in nursing experience a lot of barriers and have limited help in these sectors. And this would be a great way to partner with universities, to partner with their community partners in these community organizations to provide a better high quality end-of-life care in rural settings. Additionally, we want to encourage engagement in all clinical learning environments in caring for dying patients, not just in the home setting, but in our hospitals too. We have patients die every day, and sometimes we have bias as educators to integrate our students into those experiences because we ourselves might be uncomfortable with facing death. We might be afraid of how the student might react to a patient experiencing death. But it's really our priority to ensure that they're prepared to do this as they exit and enter the bedside. And so I really encourage all of our instructors to engage our students in death at all levels and at all settings, nursing homes, the hospitals, so on and so forth. And additionally, we want to ensure that we're providing and teaching trauma-informed care. As educators and as nurse leaders, it's really important to be mindful and intentional when we're caring for dying patients and the emotional toll that it has on the student, that it has on the nurse, and their mental well-being in relation to that. This was something that came out in my dissertation, which is currently being published. And it's really important that we focus on not only just the physical care and how to provide care, the skills, the knowledge, but also the attitudes and the emotion that come with providing care. And lastly, as nurses, we have to empower each other to be advocates, to be educators, and remember that nurse leaders come from all clinical and academic backgrounds and experiences, and not one is better than the other. And it's important to take all of our experiences to help improve care. And next, I want to talk a little bit about innovation. So some strategies for innovation related to model and utilization of end-of-life care services. So these would be strategies that expand the types of setting of care to attract more patients and meet more diversified needs. So one way to do this that has been researched in the literature is expanding community hospice homes and alternative care models. And the reason for this is this increases the flexibility and patient-centered care options in rural settings or in their community. So if we go back to our reflective activity, that patient, the closest inpatient unit to that patient was 50 miles away, and the closest hospice agency was 60 miles away from that patient's home. So on average, you have to think that when that nurse is going to make that home visit to the patient, it might take an hour to 2 hours for that nurse to reach the patient. Through the literature, there has been integrated hospice homes, which are residential facilities that are home-like, that include a bathroom and a bed, and it's a cozy environment where all of the family is welcome, similar to an inpatient facility, but really focuses on residential hospice rather than symptom management hospice. And that has to do with billing and reimbursement. But hospice homes is a great and innovative way to integrate better care in rural settings. And hospice homes are most commonly seen in urban settings or rural, urban, non-adjacent settings. But this is one way we could integrate this into a rural setting. Additionally, it would be great to leverage telehealth, that's virtual, and telephone visits, and lumped into the category of telehealth. And this ultimately reduces travel costs. It extends workforce capacity and capability of our nurses and our clinicians, and improves access for rural or homebound patients. Now, I don't mean that all hospice care should be telehealth, but it might be helpful for some our recertifications of patients. It might be helpful for our check-ins on patients and families, or understanding or hearing their describing their symptoms and their experiences in their hospice encounters. There are ways we could integrate better care in hospice through telehealth to help with the burden it puts on the nursing staff in traveling when they're short-staffed. Additionally, a big way to help lift some of these burdens is enrolling patients earlier in their diagnosis. And ultimately, this comes back down to education of the clinicians, of the nurses, of the patients and families, because oftentimes our patients are not being enrolled in hospice until until they have less than a month or left to live. And really, that leaves 5 months that that patient could have been receiving hospice services and improving their quality of care and their disease trajectory. Additionally, we want to look at engaging our community, provide community-centered education and outreach. So this way it helps the awareness. It brings awareness to these vulnerable populations. We want to utilize data to drive equity-focused initiatives to help promote inclusive, high-quality care. CMS does a really great job at breaking down who's utilizing hospice services, where they're utilizing hospice services, and why. And it's really important that researchers start to look at those minority populations that we discussed earlier, rural minority populations, as well as correctional settings, to help promote high quality and inclusive care. And additionally, it could be really beneficial as an innovation tactic to develop partnerships, strategic partnerships with community health centers, primary care providers, and other organizations to improve access to care and resources for these rural patients and their families and the carers. I know that this is something in my area specifically that is currently under the works and is in development of. And so I'm really hoping to see that some of our surrounding rural areas in the northeastern Pennsylvania region will have better access to end-of-life care and symptom management services in the future. Ultimately, some best practices and takeaways from this presentation is that interdisciplinary teamwork and communication is important and integral to having high quality end-of-life care. The earlier we're integrating hospice services to patients and families, the better quality care they're going to receive. They're going to have better dignity in their dying experience, and better symptom management too. We want to look at family-centered care models where we're putting the patient and family first at the priority of their care, and ensuring that we're keeping them there. We want to focus on continuous quality improvement. There's metrics such as the Hospice Quality Improvement Program that really helps current hospice agencies and hospice facilities look at ways we can improve and target some of these vulnerable areas. And additionally, we want to ensure we're continuing to provide trauma-informed and culturally competent care. And this is to students in education and nursing programs, but also to the staff and patients and families that we're educating in the community and in the workforce. Reaching all vulnerable populations. So I mentioned mostly today was going to be about rural communities, but I do want to highlight some other underserved communities. So for rural communities, we talked about partnership and telehealth and integrating alternative care models and really highlighting the importance on education and the exposure to education. For correctional settings, I was really fortunate to work with Dr. Susan Loeb, who I think I saw on here. So hi, Susan. And really focus on, for correctional settings and for incarcerated persons who need end-of-life care and deserve end-of-life care, focusing on policy reform to make this care accessible to patients in correctional settings. Really ensuring these patients have access to dignity and person-centered care, and improving education for the correctional staff, for the peer caregivers caring for their peer inmates, and really also improving education to nursing students and other allied services that are part of the care team when it comes to caring for incarcerated persons at the end of life. And when it comes to other minority and underserved groups, we want to focus on outreach and culturally aligned and culturally competent care, and ensuring that all of our hospice resources and agencies have the ability and are culturally competent in providing good, high quality, end of life, dignified care. Ultimately, what's important to remember is that stigma and bias perpetuate inadequate, inaccessible, and inequitable care models. And I really hope, if you take one thing away, is that I hope that you will be the nurse advocate to make an impactful change on tomorrow's care and your future patients and their families. Ultimately, education and equity are central to high quality hospice care, regardless of what area or what setting we're caring for. Nurses are pivotal in system redesign and advocacy. We're innovators, we're leaders, we're advocates, and we have the ability to really think critically to make important changes. Innovation and research can truly help close some of these accessibility gaps and utilization gaps that still persist in the literature today. And ultimately, compassion and evidence will lead to better end of life care experiences for our patients and for our families. Here are some references and resources. I mentioned CMS. Rural Health Information Hub is also a wonderful resource for developing healthcare models in rural areas. It's not specific to end-of-life care and palliative care, but they do have a section in that area. Some literature, LNAC through the American Association of Colleges of Nursing, I mentioned that earlier, and then the National Coalition for Hospice and Palliative Care, as well as the Hospice and Palliative Care Nurses Association. I'm happy to take any questions or comments or concerns. I've listed my contact information. My email is Crimi, CRIMIK @therightcenter.org, and my phone numbers are listed below. I'm happy to take any questions, and thank you all for your time.
Well, thank you, Calais, for that outstanding presentation. Thank you so much. You've given, I love the way you started it with people, thinking about possible access to care or other barriers that might impact an individual's ability to have quality hospice care, but also, the information you shared related to the need for education, not only of nursing students and other disciplines, but of practicing nurses and others as well. And then some of the innovative ideas that you shared also, are, some of those strategies just are really essential as well. If any participants have any comments or questions for Calais, please put them into the chat. Jenny will also be monitoring hands that are raised if you want to come off mute and make a comment or question aloud. Do we have one already, Jenny? Okay.
Yes,
Yeah.
we have 2 hands raised right now, so
Okay.
we'll start with Sarah Sonner, and then we'll go to Mike Atkins.
All right, I just wanted to say, this just sounds wonderful, but I think you can't see my picture, but I have gray hair. What you were talking about, and I had to deal with this when it first came out, but still it's reaching when you're talking with people in my age group, and that's who I live with, in the whole neighborhood. As soon as you say hospice, they hear it as an end of life sentence. And so you sit there and say, you have to start right away by saying, no, we really want to get you into this program because we can get you physical therapy, we can get you speech therapy. So you're dealing with 2 levels of what's going on. So they see it as that, and then to be able to get the care to them. And I've often started the conversation with, we should be so lucky that I have to do the paperwork to extend this. This is not a death sentence. You can help me do the paperwork at the end of this. And all of a sudden they'll sit up straighter and they'll do that. The other thing you talked about quickly, is the telehealth. And again, we're looking at two different levels, because one, we're in central Pennsylvania. I deal with a lot of people who do not have access, but people who want telehealth, because right now, a lot of times that's the only access they have to professional help. They load the patient. I'm quoting that and unquoting that. They load the patient into a car and go to McDonald's. I don't think McDonald's has any idea how they are the local, what they do. That's where the kids do their schoolwork. When they have to do it online, they don't have access to it. That's where students who live out from here, they're going and sitting at Sheetz or McDonald's or now the local library to be able to get access to that. So I've actually had people with telehealth that go through, they need help. How do I load her into the car? And we're going to go down, and can we do it on a phone? So you're talking about two different generations, and I love the younger people coming in, but the real life is two different populations with significant differences in access and providing care. Thank you.
That's very true, Sarah, and thank you so much for highlighting that. To your first point, I think that the United States as a whole still suffers with stigma around death, and that stigmatization really impacts everyone at the macro and micro level: our patients, our families, our nurses, our physicians, our clinicians. It impacts everybody. And that stigmatization is why we have those fearful conversations, not us being fearful, but the patients being fearful when you're doing those intake forms and having those initial conversations. And to that point, I think I tell people it's a marathon, not a sprint. Hospice, end of life care. And so sometimes people need to hear things 7 times before they're able to process that information fully. And so even if it's just starting that conversation the first time, and then the second, and then the third, eventually they might realize what might be the best option for them. And you ultimately will help guide them to what that decision would be. But sometimes it takes exposure of multiple times. To the second point, I do agree that telehealth does provide a lot of strains when it comes to accessibility of all populations. And I do know that there are some folks who work on grants to help facilities and agencies provide better accessibility to receiving telehealth services, whether that's providing or getting drivers to help get those patients to an area or a facility that provides telehealth services, and they're able to take those telehealth visits in this facility and get a driver to bring them back and forth. But again, I don't think there's anything consistent, and I don't think it's national. A lot of these are just independent agencies or organizations working on grants to help try and mitigate some of these barriers. But I'm hoping in the next 10, 15, 20 years, we're going to see improvement in that. So thank you so much for bringing that up. And they're very valid and important concerns.
Righty, next we have, excuse me, Dr. Mike Evans.
Sorry, I had to figure out how to unmute Dr. Crimi.
That's okay.
You know, my technology uses. So first I'm going to embarrass you. Clay came with me for her very first hospice experience. I'll give her credit. She was a freshman and I needed a 4x4 and she's handing me a 2x2. So I thought even as a freshman, she would know how to measure the difference between a 2x2 and a 4x4, but she didn't. But look at her now. She's now Dr. Crimi. So we'll let that go. So I didn't know my video wasn't on.
Oh, you just muted yourself again.
Boy, well, whatever. I don't even know how to do that. Okay, maybe I can't.
Okay, I don't think you can, Mike. I don't
Probably
think you
not. I'm not in a suit, as you could imagine. So, Clay, let me say this. I think nurses are the biggest advocates of palliative care. We're the ones with the patients 24/7, even if we don't know the most about it. I think incorporating into the undergraduate curriculum based on the new essentials is a necessity. But I think our biggest barrier in healthcare are physicians. And if there's any physicians on the line, I apologize. I have worked with many, as you know, especially when I worked oncology. And I have seen hospice consults literally come in, and so have you, 8 hours before the patient dies.
Yes,
It needs to end.
it does.
I don't know. You're in a position now to educate residents, but I don't know. I'm going to make it up 100 residents. I don't know how many you have.
A
That's
lot
not
more.
okay.
A lot more.
But nothing in the big
Yeah.
bucket. Nothing.
Yeah.
It needs to be in their curriculum. It needs to be in their fellowships. It needs to be, I don't know where, I don't teach in med schools, but it needs to be everywhere. Um, I have many friends who are advanced practice providers. They often are blocked by their collaborator from making the hospice referrals. So I'm going on a soapbox. I have no questions for you. You did an awesome job as always. Couldn't be prouder of you, but I hope you start the impetus of teaching the next generation of physicians about the importance of end of life care and that we cannot save everyone, unfortunately.
Yeah, thank you so much for bringing that up, Mike. And that I think is a really big barrier to the utilization and accessibility to hospice, is clinician bias and medical bias as well. And I am happy to report that I'm currently redesigning curriculum for the Wright Center, which I am focusing on integrating hospice and palliative care education into that, and ensuring all of our IM resident, our internal medicine residents, our family medicine residents, our fellows in cardiology and gastroenterology, and PM&R receive hospice and palliative care education when it comes to utilizing and accessing hospice for vulnerable populations and all patients in general. So even though it might be a small sector of all of the training residents and physicians that are out there, I'm happy to make the mark on the ones that I can for my local community. Yeah.
Yeah. So Calais, there's all kinds of positive comments in the chat about your presentation. Great job. Oh, as always, very proud of you. I think you already saw someone request the resources slide be put
Yeah, I
back
did
up.
put it back up, and
You
I can
did
put it
put
back
that-
up if people need
Yeah.
me to too.
Yeah, and if there are people that specifically want access to Calais slides, we'll talk with her about that. But send us an email with that request and we'll work towards meeting that need. Susan Loeb is on the call. She says, nicely done, Calais. Thank you for returning to the present, returning to present. Yeah. Ariel says hospice is just such a special thing for patients and families. Thank you for this lovely presentation. And Jessica Wellington says, I believe that the regs just changed and research are now required to be in person again. I think you mentioned this, and that's a potential barrier, no longer allowed by telehealth. Do you think some of the increases we have seen were due to allowing telehealth visits? How do you think this will impact future hospice care? And I would like to add to that too. I was thinking about that barrier as well from the perspective is, have they ever considered letting the RN that visits every day help to facilitate that recertification?
Yeah, those are great questions, Jess and Janice. And while I don't know specifically in the literature, because this is, as you mentioned, Jess, this is a recent change that has just happened. I'm sure we're going to see the effects of this in the literature in the coming years and in the coming reports that come out through CMS. But I do think that we're going to see some impacts from telehealth not being allowed to be utilized for recertification of hospice patients. How I think it will impact hospice care in the future is that it's going to be a barrier because we have nursing shortages, we have staff that's not able to get to these patients, higher volumes of patients with higher chronic illnesses and chronic conditions. And I think ultimately it's going to provide a lot of systemic problems on here. So I think to your point, I think it is going to cause a lot of systemic problems in the latter effect. Go ahead, Jess.
Oh, no, I just wanted to say thank you very much also. I didn't know that I could unmute myself at all. I thought this was a chat only kind of question session. So thank you very much for your presentation and for all of that knowledge. And I agree with you. I think we're going to have to watch it. And Dr. Whitaker, to your point, up until November 1, hospice RNs were allowed to help facilitate a telehealth visit with a physician to do a research. That was something they allowed during COVID, and then we just kept getting waivers that kept allowing it and extending it. And so they just ended it. And it's going to be really hard, I think, especially for those in like the rural areas, which we're talking about, where we've been able to expand during COVID to those areas, because you don't have to have a provider drive out there, right? If the nurse can do it, then the provider's not doing it. And now that's gone. So I do think it's going to be interesting.
Yeah, and I just want everyone to remember that data, the CMS data that I reported earlier. We've seen an increase overall in hospice utilization since 2020, minus 2021-22. There was a small dip. But the last 3 years, we have seen a rise, an increase in hospice utilization. And I want people to remember this as we move forward in the next year, 2 years, 3 years, and we see these reports. Remember how these policies impact patient access and utilization and how important that is. Yeah.
Do you think there's anything we can do to help reduce the stigma of hospice? Because as you said, so many, medical providers delay the recommendation to go on to hospice care, but also individuals and families are reluctant. So any thoughts about how that can be navigated a little bit better to improve earlier access to hospice care?
That's a great question. And I think a lot of it comes back to trauma-informed care and trauma-informed education of everyone, our patients, our families, our staff, the clinicians. Everyone remembers their first patient that dies. Everyone remembers a loved one or a family member that died. And that impacts them as they make their own personal life decisions as a patient, as a staff member, as a nurse, as a physician. And even as a nursing staff, you want to make sure you leave your bias at the door. But sometimes in the back of your mind, that experience, a bad experience or a good experience, can impact the quality of care and the type of care you provide to a patient. And ways I think we could overcome this stigma is, one, ensuring we have trauma-informed care and trauma-informed education. 2, providing better resources to our staff who are dealing with emotional distress or moral distress related to caring for patients at the end of life, and making that a priority. So long, we've put nurses at the bottom of the totem pole in caring for their physical and mental health, and caring for dying patients is included in that, and we need to make that a priority. Additionally, we need to get out in the community and educate and provide non-biased information so patients and families can make their own decision on what's best for them, but also make them understand what hospice is. That it's not the Grim Reaper coming after them, but rather it's a way to improve high quality care and dignified care for the patient and the family. One of our good colleagues, Kieran Riley, who's also a graduate of the Penn State PhD program and the undergraduate program, utilizes death cafes in her local community to help improve the stigma around death and dying. And so it's these small events that ultimately lead up to larger change. And so I don't think there's one right answer, but the more awareness we bring and the more we talk about it, the better it's going to get.
Yeah, thank you.
Yeah.
So lots of positive comments in the chat. Diane Barish is asking, how might supportive positions such as community health workers fit in to help alleviate the workforce shortage and access issues?
That's such a great question, Dr. Barish. And I think community health workers have such a unique perspective, and they could help a lot with the barriers, some of the barriers to care when it comes to accessing such as they could help with transportation if needed. They could help with utilization of telehealth and integrating online services into their appointments. They really work as a liaison or a leader in helping these patients access better care. And I think that community health workers often are underutilized in hospice and palliative services, but are really, excuse me, really important because they ultimately help take the patient's needs and concerns and help us bring the right team members in to address their care needs. So that's a great
Yeah,
question.
that's an excellent point. Well, Calais, thank you so much for this very informative presentation, but your, expertise, I think we all learned so much today and you gave us so much to think about and advocate for. So thank you so much. And what a great month to do this presentation in, Hospice and Palliative Care Month. So thank you for sharing this and the wonderful resources that you did as well. A
Yes.
quick reminder to participants that the evaluation tool will pop up in your browser when the webinar concludes. So you can complete it then, or you can complete it when it comes to you via email within the next 24 hours. But thank you again, Calais. Thank you, Jenny and Solomon, and all of you that joined us today. Have a great rest of your day.
Thank you, everyone.